acute kidney injury is an abrupt, so less than 7 days, and sustained, so more than 24 hours, decline in glomerular filtration rate. And this term covers a wide spectrum of disease, from mild to severe, and the causes are, as with everything, numerous and multifactorial. So risk factors for AKI, you'll see that a lot of our patients have most of these. Age, over 65, those with pre-existing chronic kidney disease, diabetics, anyone with critical illness, anyone with sepsis, anyone with cardiovascular disease, anyone undergoing emergency surgery, and the use of nephrotoxic drugs. Causes classically are divided into pre-renal, renal and post-renal. So pre-renal is by far the most common cause of AKI. So this covers things like hypovolemia. Now whether that's relative, as in they've got vasodilation or they've got third spacing and lots of fluid in the wrong places, or absolute, where they are dehydrated through volume loss. Sepsis, causing vasodilation and reduced effective circulating volume. Low blood pressure, which will reduce your renal perfusion pressure for any reason. And then renovascular disorders, so if there's a disorder of the actual renal artery itself, whether this is vascular disease causing stenosis or whatever, will also cause pre-renal AKI. And often this is multifactorial and a combination of things. Intrinsic or renal causes, so nephrotoxic drugs are a big one, particularly things like aminoglycosides like gentamicin, non-steroidal anti-inflammatory drugs, ACE inhibitors, IV contrast, etc. Although IV contrast and its role in AKI is debated. Other weird and wonderful things like glomerular disease, various autoimmune things, vasculitis, that sort of thing. Hemolytic uremic syndrome and rhabdomyolysis, where there's direct tubular damage. And then post-renal is essentially obstruction at any point, but abdominal compartment syndrome can also cause post-renal obstruction, post-renal AKI, and it can also contribute to pre-renal by reducing the renal perfusion pressure. And post-renal AKI is a very important thing to exclude in patients presenting with AKI, which is why we will image the urinary tract. There are various different classification systems of AKI. One of the most common systems used in the literature is the rifle classification, which divides the patients into risk, injury, failure, loss, or end stage, depending on their creatinine and their urine output. And it's quite simple to remember initially, is where the creatinine is seen at 150% increase, a 200% increase, a 300% increase, and whether the urine output's been less than 0.5 ml per kilo per hour for 6 hours, 12 hours, or whether they've had a urine output less than 0.3 ml per kilo per hour for 24 hours or been anuric for 12 hours. Where they meet the criteria for loss, this is where things are persistent for longer than 4 weeks, and then end stage, where they are persistent for longer than 3 months. The KDIGO classification is becoming more common in clinical practice, and this comes from a 2012 definition. And it's where you see a serum creatinine rise of 26 micromoles per litre within 48 hours, or the serum creatinine rising by 150% of the patient's baseline value, or they have a urine output of less than 0.5 ml per kilo per hour for 6 hours. And this can be staged into stage 1, 2 or 3, and often our blood results system will give you the stage of AKI it thinks the patient is in based on the change in creatinine. But again, it's similar to the rifle criteria in the sense that it's 1.5 times baseline, 2 times baseline, or 3 times baseline. And again, the urine output classification and criteria is the same. If a patient is started on renal replacement therapy, they automatically become stage 3. The implications of this are related to mortality and the requirement for renal replacement therapy. So we're going to use the rifle criteria here, but you can use the KDIGO classification where risk is stage 1, injury stage 2, and failure stage 3. As you can see, they're actually related to mortality, in that if a person has stage 3 AKI, then they have a mortality rate of 26.3%. And overall, purely having AKI is associated with a 13.3% mortality rate. If you're critically ill with AKI, however, this could approach 50%. So it's very important that we pick this up and we manage it correctly. Here's a Kaplan-Meier survival curve showing the percentage of patients surviving to hospital discharge based on the stage of AKI. And as you can see, the more severe the stage of AKI they have, the less chance they have of leaving hospital alive. So what implications does AKI have to us as clinicians? Well, it's more than just the urea and creatinine on the blood test. It really is a multi-system disorder. So you have disorders of the fluid balance, where you might get volume overload due to reduced urine output and pulmonary edema. You'll get metabolic acidosis, hyperchloremia due to inability to excrete chloride ions, accumulation of phosphates, and inability to regenerate bicarbonate, all contributing to a metabolic acidosis. Electrolyte derangements are common and often are a reason that we would start renal replacement therapy in an emergency, and particularly hyperkalemia, but we will also get hyperphosphatemia as well. Uremic problems are less common and less commonly seen, but the textbooks will say that you can get encephalopathy and pericarditis with very high ureas. Hematologically, you'll see decreased red blood cell synthesis, so you may get an anemia, and also decreased von Willebrand factor, so you may actually see increased bleeding time. In terms of the gut, well, the gut may be edematous due to fluid overload, and this could lead to poor absorption, and in worst case scenarios, even abdominal compartment syndrome. And then we have to think about the drugs we give these patients as well, because those drugs that are eliminated by the kidney will accumulate, and due to the increased amount of fluid on board that the patients have, these drugs will have an increased volume of distribution. So with any assessment of any patient, ABCDE is always the exam answer. We're going to take a history, we're going to check for the presence of nephrotoxic drugs and assess which ones can be stopped. We're going to assess the patient's blood pressure and circulation, see if it's adequate for renal perfusion. We're going to assess the fluid balance, see whether the patient's hypovolemic, dehydrated, with their fluid overload. And then we're going to examine the patient, look for things like presence of a distended bladder to suggest a post-renal cause or signs of dehydration, and any precipitating cause that we might find, for example, a pneumonia. And then in terms of investigations, obviously we're going to send off some blood tests. For specific investigations, aside from our normal blood tests, it's important to do a urine dipstick, because we need to consider an intrinsic renal disease process when the urine has hematuria and proteinuria, particularly in the absence of infection, and this should prompt a rapid referral to the renal physicians to help us diagnose some weird and wonderful intrinsic renal problem. We need to image the renal tract. This isn't necessarily required in all patients according to NICE when the cause is known. I would suggest that in most of our patients presenting critically ill with undifferentiated organ failure, the cause probably won't be known, and we need to check. But particularly when you suspect pyonephrosis, so people with, say, pyelonephritis that are very, very septic and very, very sick, you need to be imaging that renal tract quickly within 6 hours. Now, this may not be practical, particularly overnight where ultrasound scans are less available, in which case you could do a CT-KUB to rule out renal obstruction. And then if you suspect urinary tract obstruction through some other cause, they should have their renal tract imaged within 24 hours. In terms of blood tests, it's useful to check a CK, particularly where rhabdomyolysis is suspected. And then there's other things such as autoantibodies, particularly things like anti-glomerular basement membrane antibody and ANCA, that you can request if an autoimmune cause is suspected as part of the renal screen. So the management largely depends on the severity, but in general, we're going to remove the precipitants, whether that be hemodynamic disturbance, infection, drugs. We're going to provide supportive care. We're going to relieve obstruction where it's present, for example, by doing a nephrostomy. And if needed, we're going to provide renal replacement therapy. So renal replacement therapy is an umbrella term, and it's essentially any therapy that's used as a life-supporting treatment for renal failure. So this could be things like intermittent hemodialysis that a lot of patients are on in the community, peritoneal dialysis, again, that some patients use at home, and then continuous modes like continuous hemofiltration, continuous hemodiafiltration, and then slow continuous ultrafiltration in some units as well, mainly for fluid removal. The indications for renal replacement therapy are listed here, and these are known as the emergency indications. So these are refractory volume overload, life-threatening hyperkalemia, symptomatic uremia, metabolic acidosis, or specific drug involvement, particularly things like lithium, ethylene glycol, methanol, salicylates, and metformin. Other relative indications: hyperthermia, so in a patient who's got renal failure and has a very, very high temperature, persistently over 40 degrees, the use of renal replacement therapy can be a very easy way to bring that temperature down because it's an extracorporeal circuit that we can control the temperature of. Rhabdomyolysis, there's an indication for early renal replacement therapy in rhabdomyolysis where the CK is very, very high. I think this may limit the damage to the tubules that is caused by the CK. Liver failure, so particularly acute liver failure, hyperammonemia is an indication for renal replacement therapy. Where someone's got acute liver failure, particularly from things like paracetamol overdose, when their ammonia hits 150, they need to be going on renal replacement therapy because that's directly linked with raised intracranial pressure and cerebral edema and death. So that's a very important indication. And then there was a vogue for doing it for severe sepsis, the thinking being that we'll remove all the endotoxins and improve the cardiovascular state and the outcomes, but the evidence on that is not really supportive. So hemofiltration, this is a common continuous mode used on critical care, and it uses the principle of ultrafiltration, which is the movement of fluid through a semi-permeable membrane. And then with this ultrafiltration, you'll get the process of convection happening. And this is the movement of molecules through a semi-permeable membrane associated with fluid during ultrafiltration, otherwise known as the solvent drag. And because it's under pressure, it's independent of concentration gradient and instead is determined by the transmembrane pressure. So the solute transfer is dependent on the solute itself, so the size of the molecule, the charge, how heavily protein bound it is, the dialysis membrane, so the type of membrane, the porosity, the thickness, the surface area, and the transmembrane pressure, the rate of solute delivery to the filter, so this is the blood flow, the concentration gradient between blood and dialysate in intermittent hemodialysis, and the ultrafiltration dose in continuous veno-venous hemofiltration. So this is essentially how much filtration is happening in mils per kilo per hour. So this is a schematic of a hemofiltration circuit. We can see blood from the patient enters at the top. There's an anticoagulant of some form injected. And then there may be some pre-dilution happening with some replacement fluid put in before the filter. The blood will then pass through the filter where it's pressurized, causing ultrafiltration and solvent drag for removal of fluid and solutes. The blood will then pass around where the anticoagulant may be reversed. There's an airlock and a post-dilution addition, and then the blood is returned to the patient. The fluid balance of the patient at the end of this is determined by how much fluid is replaced compared to how much is removed. So this does require large vascular access. So you need a large dual lumen central venous catheter, which may be sort of 12 to 14 French, because the flows you'll need through this could be up to 300 mils per minute. and we would commonly use the right internal jugular vein as our preferential site for these. Anticoagulation, this is kind of an entire talk in itself, but in general the main anticoagulants used are heparin, citrate, prostacyclin, and low molecular weight heparin. The two common agents we would use at Aintree would be heparin or citrate. So the rate of filtration is mainly determined by transmembrane pressure and the blood delivery to the filter. So the flow rate through the machine and the pressure across that filter. The type of membrane can then dictate which solids are removed, for example, how big the holes are in the membrane and what the membrane's made of. It's a very effective method for fluid removal because we can remove a lot of fluid and not put much back in. And often middle-sized molecules are said to be better removed than with intermittent hemodialysis, which is why there was a thought that this would be useful in sepsis, as you'll be removing all those cytokines and other inflammatory mediators. And that effluent flow, so the amount of fluid coming off that filter, is the dose that we prescribe, the ultrafiltrate dose. The replacement fluid is a buffered crystalloid solution, and pre versus post dilution is always a consideration. Most commonly, you'll put in a third of the dilution, a third of the replacement fluid pre-filter and 2/3 post-filter. Now you can change that if the filter keeps clotting and you want to run the blood more dilute through the filter, but the trouble with that is you will reduce the efficiency of your renal replacement therapy because you're running a more dilute blood solution through the filter, which will reduce your solute removal. And the contents of the replacement fluid is largely determined by your electrolyte goals. So in general, the two things we would change would be the potassium content. So we have bags that have potassium at 4 millimoles per litre and bags that have potassium at 2 millimoles per litre, and how high the potassium is will determine which of those is chosen. And the volume of replacement is determined by fluid balance goals. Intermittent hemodialysis uses the principle of diffusion, and diffusion is the movement of molecules from an area of high concentration to an area of low concentration. And essentially the electrolyte solution, which is the dialysate, runs countercurrent to blood flow separated by a semipermeable membrane, and this countercurrent flow ensures that there is a concentration gradient maintained at all times. It does require the correct water supply to make sure that the endotoxin levels in the water are low enough, and it's possibly less cardiovascular stable because the fluid is removed over a much shorter time and there is significant osmotic effects when the fluid moves around in the tissues. Anticoagulation, as I've mentioned, most common things used are heparin, citrate, prostacyclin, low molecular weight heparin. You can use argatroban as well, particularly in the setting of heparin-induced thrombocytopenia. But in general, heparin and citrate are the most commonly used, and on our unit, citrate is by far the most common mode rather than heparin. So heparin potentiates antithrombin 3, causing inhibition of thrombin, and therefore without thrombin you can't convert fibrinogen to fibrin. And this will anticoagulate the whole patient and the circuit, and we'd usually target an APT ratio of 1.5 to 2. It's cheap and simple, but there is the risk of bleeding and heparin-induced thrombocytopenia, and often there's a delay in achieving the therapeutic anticoagulation you need. So if you start the renal replacement therapy and the heparin at the same time, often there'll be a period of time where that filter is not anticoagulated, increasing the risk of clotting. Citrate is the most common mode of anticoagulation we use at Aintree. This is administered as trisodium citrate pre-filter, and this will chelate calcium, preventing the activation of thrombin. And after the filter, calcium is replaced. Therefore, only the filter is anticoagulated, so we refer to this as regional anticoagulation. This citrate calcium complex is largely filtered out through the filter and removed in the ultrafiltrate, but some is returned to the patient and metabolized in the liver. And 1 millimole of citrate is metabolized to 3 millimoles of bicarbonate, and therefore there's less need for a buffered replacement solution because you're providing a buffer to the patient in the form of citrate. It's important that we measure the calcium and monitor it closely. So the post-filter ionised calcium is watched very closely, because this will tell us if the patient's getting enough citrate. And again, we'll keep an eye on the systemic ionised calcium as well, to ensure that the patient is getting enough replacement calcium and isn't getting toxic from the citrate. You do see complications though. The most common one would be metabolic alkalosis, and as I've said before, citrate is metabolized to bicarbonate. But also the citrate anion is metabolized more than cations, which means that you have a relative lack of anion, and this will increase your strong ion difference, leading to an alkalosis by itself. If you start to get an alkalosis, you may need to decrease the citrate dose, decrease the flow rate, or even stop the ROT altogether and use an alternative for anticoagulation. But happily, this tends to develop over a longer period of time, sort of 12 to 24 hours rather than acutely, and usually represents the fact that the filter is getting clogged up, and less citrate is being filtered out, so more is being returned to the patient, and therefore more is being metabolized to bicarbonate. So to fix this, the only way to change it is to change the whole filter in the circuit. But you can become toxic from citrate, and things you'll see with this are where you have a metabolic acidosis, you'll have a low ionized calcium because the citrate is chelating all of it, but you have a normal or high total calcium, and this low ionized calcium causes myocardial depression, hypotension, tetany and weakness. The sodium cation is preferentially removed through the filter more than the citrate anion, and therefore you have more anions being delivered back to the patient in the setting of toxicity, which will increase your anion gap and decrease your strong ion difference, leading to a high anion gap metabolic acidosis. And this excess citrate binds ionized calcium systemically, leading to low ionized calcium. So it's important that we keep a close eye on the calcium levels, because that will give us the first clue. And in fact, you can do a total to ionized calcium ratio, and if this is over 2.25, this is strongly suggestive of citrate toxicity, and that we would refer to this as the TI ratio. So troubleshooting, almost universally, the problems we run into are line issues and clotting issues. So if the nurses are coming to you and saying that the machine is alarming and saying that there is low access pressure, the machine will tolerate a negative pressure of sort of minus 250 millimeters of mercury before alarm starts sounding. And this is essentially the measure of negative pressure generated by the pump sucking the blood out of the patient. And this is almost always a line issue. So the line might be kinked, the tubing from the line might be kinked, the line may be sucking against the vessel wall. This is particularly common with left internal jugular vein HF lines, because of the longer course they take through the body. It may be that the line's become occluded with clot, or it might be that the blood flow to the line is poor. So the patient might be hypovolemic, they might be increased intrathoracic or intra-abdominal pressure, which will decrease your venous flow past the catheter tip, or the patient is breathing very heavily without positive pressure ventilation and is hyperventilating. And this means their deep breaths create a more negative intrathoracic pressure during inspiration, which pulls blood in the opposite direction out of the HF line, essentially. High return pressure, the machine will tolerate up to sort of positive 300 millimeters of mercury before alarm sounding, and this is a measure of the pressure generated by the pump pushing the blood back into the patient post-filter. And again, almost certainly this will be a line issue. So it might be that the line or tubing is kinked, the return lumen is trapped against the vessel wall, the line has become clotted, or the line has become dislodged and the return lumen is emptying into a hematoma, or perhaps most seriously, the line was inserted into an artery and nobody noticed. High transmembrane pressure is another thing that causes a lot of problems. This would usually be about 100 to 150 millimeters of mercury, and the alarm limits will vary by machine, but it's usually around 300. And there is an equation to calculate transmembrane pressure, but helpfully the machine just gives it to us. And it's related to the relationship between the pre-filter pressure, the return pressure, and the effluent pressure. and it's essentially the pressure across the filter. So if you have a high transmembrane pressure with a normal return pressure, this is a filter problem. If you have a high transmembrane pressure with a high return pressure, this is a filter or a line problem. Coagulation issues. Well, thankfully, we have protocols and guidelines to manage coagulation, and the nurses are expert at managing this. In general, just follow the guide on the prescription chart of the RRT. Most importantly with citrate, correct the hypocalcemia. But always be aware of citrate toxicity as a cause of deterioration in a patient on renal replacement therapy. One tip is to smile and nod when the nurse tells you the post-filter calcium. There is a box on the guideline that tells the nurse when they have to inform a doctor of what the post-filter calcium is, if it's too high or too low. They will almost always have already fixed this by the time they come and tell you. So just smile and nod. But if you're unsure, ask somebody. In terms of when to stop renal replacement therapy, there's no real evidence regarding the right time to stop. We know that urine output is the most successful predictor of when renal replacement therapy can be stopped. And in general, if you have over 400 mils of urine output in 24 hours without diuretics, this will predict success of discontinuation. Sometimes the urine creatinine will continue to rise once the renal replacement therapy is stopped, but whilst they've got a good urine output and no emergency indications to restart, we'll often hold our nerve and just monitor how things are going. So in conclusion, AKI is a serious condition and carries a mortality risk related to the severity. And it's important not to forget the basics and to correct the precipitating factors when they come to us. We should consider emergency RRT if the patient is uremic, if they have potassium over 6, if they've got severe metabolic acidosis, if they've got pulmonary edema, or if they're anuric.